The last section in the GI pathology chapter is colorectal carcinoma. This is a carcinoma that arises from the colonic or rectal mucosa. The peak incidence is about 60 to 70 years of age. Recall that colorectal carcinoma is the third most common site of cancer when you exclude skin, and it's also the third most common cause of cancer-related death. Now, when you think about the molecular mechanism by which colorectal carcinoma can arise, there's really two major molecular pathways. The first molecular pathway is the adenoma-carcinoma sequence, and we discussed the adenoma-carcinoma sequence in extensive detail in the prior lecture. However, this is the most common pathway by which colorectal carcinoma would arise, and it probably represents about 80% of colorectal carcinoma. There's a second important molecular pathway, and that's the microsatellite instability pathway. Now, what is this pathway? Well, let's begin by reminding ourselves about what microsatellites are. So microsatellites are repeating sequences of non-coding DNA. They're present in our DNA. And every time we have cell division and we copy our DNA, we also copy the microsatellites. Normally, when we have cell division, we will copy the microsatellites exactly the way they are, and we call that microsatellite stability. Now let's pretend, for example, or let's assume, for example, that the patient has some defect in DNA copy mechanisms. For example, they have a problem with their DNA mismatch repair enzymes. Well, in that particular case, they may not be able to maintain the stability of their microsatellites as they copy the DNA over and over again, and this would introduce something called instability, and that's exactly what we mean when we say that there is a molecular pathway called microsatellite instability, i.e., there are problems with the DNA copy mechanism so that the microsatellites become unstable. Now, of course, if the microsatellites are unstable, that's a sign that other genes would also be unstable, and therefore and mutations in other genes could potentially lead to the development of a colorectal carcinoma. The prototypic example of this particular pathway, of the microsatellite instability pathway, is called hereditary non-polyposis colorectal carcinoma. Now, hereditary implies that it's an inherited problem, and in fact it's an inherited mutation in the DNA mismatch repair enzymes. Non-polyposis indicates that the tumors usually arise de novo, meaning you don't get an adenoma that becomes a carcinoma, you simply get the carcinoma over time. And then colorectal carcinoma indicates what type of tumor these patients get. They have an increased risk for colorectal carcinoma. However, because there is an inherited defect in all of the cells, there is also an increased risk in a couple other organs. In particular, it's worth knowing that patients with HNPCC also have an increased risk of ovarian and endometrial carcinoma, and that's particularly high yield to know, that these patients get basically three types of tumors: colorectal, ovarian, and endometrial carcinomas. So these are the two pathways by which colon cancer can arise, and it's probably important to note that there's sort of a couple other patients that classically also get colorectal carcinoma that you also want to think about when you think about pathways per se. One would be to remember that patients with ulcerative colitis have an increased risk for colorectal carcinoma, and that sort of occurs independently. It's really the chronic inflammation that leads to the increased risk for the development of cancer. And then remember that patients with Peutz-Jeghers syndrome also have an increased risk for colorectal carcinoma. So there are a few others. However, of course, the two major pathways and what represents the vast majority of colorectal carcinoma is the adenoma-carcinoma sequence. That's one example. And then the other one would be the microsatellite instability pathway, the prototypic example of which is HNPCC. Now, screening for colorectal carcinoma, just generally speaking, it occurs via two mechanisms. Number one is colonoscopy, and I note here that your book actually says endoscopy, and I'm purposely highlighting this for you. It should not say endoscopy, it should say colonoscopy, so please do correct that. So again, the first mechanism for screening for colorectal carcinoma occurs via colonoscopy, and the second is fecal occult blood testing. Usually we begin screening at the age of 50. The idea for colonoscopy is to remove adenomatous polyps. Again, you want to remove all polyps because you can't tell which ones are adenomatous when you do the colonoscopy. However, the goal was to remove the adenomatous ones. And so we remove the adenomatous polyps before they can become cancer. And at the same time, we also try to detect cancer before it presents any clinical symptoms. So that's the goal of colonoscopy. Fecal occult blood testing does the same thing. It also has the ability to detect bleeding, and bleeding could be seen with polyps and it could be seen with cancer. So it's a mechanism by which we are, again, trying to detect both polyps and, again, also trying to detect cancer before clinical symptoms arise. Now, it's important to also note that cancer can develop anywhere along the entire length of the colon. Left-sided carcinoma usually grows as a napkin ring lesion, and the idea here is that if you've got a left-sided cancer, it tends to grow circumferentially around the entire lumen, and it squeezes down on the lumen as if a ring would squeeze on a napkin. And so they call that a napkin ring lesion. Now, the classical clinical features of such a lesion would be that there would be decreased stool caliber. Now, imagine if the stool is coming through here, as it gets squeezed to the napkin ring, it will create pencil-thin stools. And so the stool caliber would decrease. There could be left lower quadrant pain. There could also be blood streaking on the stool. But I think the number one thing is here, the decreased stool caliber. Also important to note that the adenoma-carcinoma sequence tends to be more on the left side than it is on the right side. At the same time, we can also develop right-sided carcinoma, and the interesting thing about right-sided carcinoma is that it tends to grow as a raised lesion. So if this is the right side, it tends to grow as this kind of bump or raised lesion on the surface of the colonic mucosa. Now again, this isn't a polyp. It's not arising from an adenomatous polyp. It just simply grows as a raised lesion on the surface. This would then result in iron deficiency anemia. The right-sided colon is has a much larger luminal caliber than the left side, and so you don't really get obstructive symptoms. You get bleeding. In particular, you can see small amounts of bleeding, which would slowly over time result in an iron deficiency anemia. And you would also get vague pain. Now again, right-sided carcinoma is more classically associated with the microsatellite instability pathway. Again, important to note, left-sided usually associated with adenoma-carcinoma sequence, and right-sided usually associated with the microsatellite instability pathway. Generally speaking, when patients have colorectal carcinoma, there is an overall increased risk for Streptococcus bovis endocarditis, so that if you have a patient and they have endocarditis and there's Streptococcus bovis growing in the blood, you better really think twice about colorectal carcinoma. And you can guarantee yourself that this is the type of thing that examiners love to ask about. They give you a history of a patient with endocarditis, they tell you that it's Streptococcus bovis, and then they ask you what you need to do next. And of course, you need to examine the GI tract, in particular the colon. Now, the staging for colorectal carcinoma, the T stage is based on the depth of invasion. Again, generally speaking, when you have a hollow tube and you have a cancer growing in that hollow tube, depth of invasion becomes particularly important for that T staging. At the same time, the N stage is based on spread to regional lymph nodes, as it would be in almost every organ. And then the M, or metastasis, is based on distant spread. And it's important to note that the most common site of distant metastasis is actually the liver. So that's where colorectal carcinoma would go once it leaves the region. An important tumor marker is CEA. Now, remember, tumor markers, generally speaking, can have three possible benefits. You can use tumor markers for screening, you can use them to assess treatment response, and you can also use them to assess or detect recurrence. In this particular case, CEA is not useful for screening. It is useful for it is useful for assessing treatment response. If the patient has an elevated CEA at the time of diagnosis, you would look for the CEA to decrease after response. And also, if the patient had an elevated CEA at the time of diagnosis and is then treated and then comes back with signs and symptoms that are worrisome for recurrence, you could use it to detect recurrence. So these are the two benefits of CEA. And with that, we close off our GI pathology chapter.